Hi, this is Dr. Bernstein with your July 2016 teleseminar. I give you, again, our usual warning that most of the information that I have from the questioners is incomplete. I can't possibly have a full history and physical exam on each patient who asks a question. So I can't possibly give a completely accurate answer. The answers, however, are interesting to the entire group, but please don't go and do something based upon my response because it could be totally incorrect. Our next teleseminar will be on Wednesday, August 31, 2016. Our special subject for today is update on adverse effects of oral anti-diabetic agents. Not all bad, but physicians should be cautious. Now, it's interesting. I keep encountering coincidences almost every day in my life. I decided on this subject yesterday. Last night, I got the current issue of the Journal of the American Medical Association, and their feature article is entitled Comparison of Clinical Outcomes and Adverse Events Associated with Glucose-Lowering Drugs in Patients with Type 2 Diabetes. Here's the article. Now, it's very interesting that the conclusions of this Cochrane survey of hundreds of studies of oral anti-diabetic agents were that and they compared them mostly to metformin, which was sort of a gold standard. And their comparison was that adverse effects were minimal and almost not different from metformin for just about everything. My experience does not quite jibe with this, and what I'm going to talk about is my experience. I'm going to go down each of the oral agents that are used to treat type diabetes. The first one is a class called alpha-glucosidase inhibitors. This includes acarbose, glycet, and other similar products which are intended to inhibit the digestion of simple polysaccharides, that is, sugars that are not pure simple sugars like glucose or fructose, but are maybe 2 or 3 glucose molecules stuck together, things like what you see in bread, starches. So here we have the American Diabetes Association advocating that you eat a lot of starches, and then they want you to take an alpha-glucosidase inhibitor to stop you from digesting the starches because they know the starches are going to raise your blood sugar. It's sort of crazy. Their favorite starch is whole grain breads, but they also have fruits in there, and the alpha-glucosidase inhibitors will reduce the adverse effects on blood sugar of eating these foods. Will not eliminate it, will not greatly eliminate it, but will somewhat reduce these effects. The only adverse effect of the alpha-glucosidase inhibitors stems from the fact that you end up with these simple polysaccharides getting into the lower intestines where bacteria can digest them, create methane and possibly other gases, and cause flatulence. And the only hazard of flatulence is if you happen to be standing near an open flame, you can experience what the Italians would call un'esplosione, come un colpo di cannone. So if you're using these alpha-glucosidase inhibitors, which make no sense to begin with, just stay away from an open flame. The next category I'll mention is thiazolidinediones. That's Actos and Avandia. For a while, there was a big scare about bladder cancer, which is a very rare condition, and so rare that with or without the thiazolidinediones, it was almost impossible to find. And eventually, the scare was removed, but people are still asking questions in my teleseminars about the hazards of bladder cancer. There ain't no hazards. Several studies have been unable to find any association. There are associations, mild associations, with bone loss or bone fractures, and there's still a warning associated with congestive heart failure, which has, I believe, recently been retracted, but I am not retracting it fully, because both Avandia and Actos, but mostly Actos by far, foster fluid retention in the body. And if you already have congestive heart failure, your heart is too weak to pump a lot of fluid around your body, a lot of blood. So one of the treatments for CHF is a diuretic to make you pee away fluid. But Actos causes fluid retention. So it might be hazardous for people who already have congestive heart failure. I happen to be personally prejudiced against excess fluid retention, so I teach my patients who use Actos to check for edema or swelling in the legs. And we do this for a little test where you press on your tibia, looking for what's called pretibial edema. And this test is demonstrated in one of my videos. So if you go through the 100 or more videos that I have on YouTube and on Facebook, you can see my test for pretibial edema. So if I put someone on Actos, number one, I know in advance that they don't have congestive heart failure. I wouldn't use it on such people. And two, I don't want them to get swelling in their legs. My reason for prejudice against this swelling is that I was director of the wound care clinic at a major university hospital. I worked there for 27 years, and the most common wounds of the legs that we saw were venous stasis ulcers. And these are caused by fluid retention in the legs. And so that's why I'm prejudiced against fluid retention in the legs. In any event, you have to check for pretibial edema, and if you're taking Actos, and to a lesser degree if you're taking Avandia, your doctor should teach you how to check for pretibial edema. The next category is sulfonylurea drugs and glinides, which are similar to sulfonylurea. These are drugs that cause the body to make more insulin if it's capable of making insulin. Now, there are some problems with this. According to the ADA, which still classifies these as major treatment options, and cite as the only adverse effect possibility of hypoglycemia if you use them incorrectly. But there's another effect that they don't mention. Back in the 1970s, I guess, there was a major study of the sulfonylureas because they were the only agent we had the only oral agent we had for treating type 2 diabetes. It was called the University Studies Group. And this study showed a very substantial increase in heart attacks amongst the people who took sulfonylureas. There was some question about the accuracy of the study, but the numbers seemed to be pretty overwhelming. So certainly low carbohydrate diets would have been much more effective than the sulfonylureas, but people weren't going to try low carbohydrate diets then. They were worried about fats. So here we had the entire diabetes profession was switching to sulfonylureas because there was nothing else available. And since that time, there have been repeated studies of association with heart attacks done in a variety of countries over the years, and these don't get mentioned in the Cochrane study that's being quoted in the Journal of the American Medical Association this week. I don't understand it. These studies have been repeated, and sulfonylureas, and I assume because they're similar, the glinides are hazardous and should be avoided. So I stopped prescribing those things after I was in practice only a few years because of the hazards associated with them. Next on the list is the GLP-1 agonists, glucagon-like peptide 1 agonists, Byetta, Victoza, etc. I've discussed these at great length on my teleseminar and also on my Dr. Bernstein's Diabetes University videos. And they have very little effect directly upon blood sugar, but they can have considerable effect upon appetite. The major adverse effect is that they slow digestion, which could be good because if you're a type 2 diabetic, your slow insulin production can cope with slow stomach emptying better than it can with rapid digestion. So you might say that slow stomach emptying is an advantage also, but they can cause constipation, maybe nausea, but these are rare, relatively rare and mild. However, there is a package insert warning about pancreatitis, and everyone is pretending that the pancreatitis is so rare that you can not worry about it. Well, I was worried about it. So when I put a patient on a GLP-1 agonist, I test them for pancreatitis. And how do I do that? The next time I draw bloods, I measure their pancreatic lipase and pancreatic amylase. And the more important one is the lipase. And what I found is, over the course of a year or so, 3 people developed elevations. 2 of those people developed symptoms. 1 of them developed very severe symptoms and was about to go to a gastroenterologist when I called her and told her to stop the product. And sure enough, her symptoms went away. And not only did she have severe GI distress, but her serum protein dropped dramatically. And this is characteristic of pancreatitis, where the injured pancreas is leaking protein into the abdominal cavity, so that the total serum protein level drops off. So here, in 1 year, the handful of people I had put on these agents were, 3 of them got pancreatitis. So my warning is, yes, you can use GLP-1 agonists, Byetta, Victoza, Amylin, Symlin, and so on, but the doctor should be testing the patient periodically for at least pancreatic lipase. And if you find any elevation of lipase, you have to stop the product right away. Don't even assume it's due to another cause. Stop the product and see what happens to the lipase level. Next is the DPP-4 antagonists. This is a class of drugs like Januvia, and there's a group of them that are similar. These drugs inhibit the enzyme that destroys GLP-1. And the product is relatively benign, but it has virtually no effect on blood sugar. Why the FDA approves something that has no effect on blood sugar, I don't know. However, there is some evidence that they foster beta cell recovery. And therefore, on my teleseminars, I was advocating the use of DPP-4 agonists to foster beta cell recovery. And then came some reports that they increased the incidence of heart failure. So I advised on my teleseminar, you better not do this. Don't use them. And I advised that a month ago. But lo and behold, we now have new studies that have come out that have relinquished the inhibition of the DPP-4 agonists on account of heart failure. They supposedly do not cause heart failure. So I now can recommend them again for helping to foster beta cell recovery in a newly diagnosed diabetic or in a borderline patient or a pre-diabetic patient. They can foster beta cell recovery. So DPP-4 agonists would be back on my book for that purpose. One thing I forgot to mention when I was talking about the GLP-1 agonists, their only purpose, as far as I'm concerned, is to curb appetite. And we've discussed that at length. They can be very effective, but for many people, they stop working after a few months. So it's not like they're an absolute answer to curbing appetite, but they may be effective. I also should point out that the GLP-1 agonists that are sold to take once a week are not focused on the time of the day when you're overeating, so they're less likely to adequately affect your appetite. You're getting their effect all day long, and you're going to be developing a tolerance much more rapidly. Another oral anti-diabetic agent is the class of agents called SGL2 inhibitors. These include Invokana, and are agents that cause you to release glucose into the urine at a relatively low blood sugar. So instead of the renal threshold for glucose being, let's say, 160 milligrams per deciliter, you may start peeing away glucose at a blood sugar of 130 or 120 or 110 milligrams per deciliter, thereby eliminating sugar from your bloodstream via the urine. Uh, According to the literature, the major potential adverse effect of this would be urinary tract infections. I have one or two patients who find this extremely effective, like it very much, but there is a catch. You have to drink a lot of fluid because you're going to be peeing away a lot of fluid. You also have to urinate a lot. And if you're not drinking a lot of fluid, you can get dehydrated. And on the few patients that I've used this for, I have seen signs in their blood tests like a high hematocrit, that is, high red blood cell concentration, indicates that you have too little water in your blood. Or we'll see abnormalities in serum sodium level. So it is possible to get potential problems if you get dehydrated, or even if you drink too much fluid, you could be peeing away a lot of sodium. So there are potential problems. The doctor should be ordering blood tests every few months for sodium chloride, hematocrit, just to make sure that things are running normal. And as I said, some of my patients have found these to be extremely valuable, and therefore I can't say I won't use them. I'm just very reluctant to use them because it means more work for me. I have to keep on top of those patients and retest their bloods periodically. And that's basically the story with that group of drugs. SGLT2 inhibitors. Last on the list is metformin, which, for wise reasons, the American Diabetes Association has selected as their number one oral agent, the thing that you try first. And I agree with that, but there are two categories of side effects. First category is GI disturbance, diarrhea usually. And for that reason, it should be started slowly and started with the timed release version, not the rapid acting version. And the time release should be taken in the lowest possible dose, 500 milligrams, at the end of a meal to minimize the likelihood of diarrhea. And then if you don't get diarrhea, you can add to the dose, taking it at another time of the day. And you can eventually, if so desired, switch from the slow release metformin to the rapid release if you want more rapid action before meals. The other side effect is inhibition of vitamin B12 absorption. Metformin has most of its effects in the intestines, and one of its adverse effects is the potential for inhibiting vitamin B12 absorption. And this should not be ignored. I have not seen this happen, but it's been repeatedly reported in the literature. And the articles that I read say that if you consume calcium at the time that you take the metformin pill, you will eliminate that side effect. Well, that doesn't mean that you take a Tums whenever you take a metformin tablet. It means that your doctor first checks your B12 levels before starting the metformin. And because serum B12 levels vary from day to day widely depending upon what you ate, you want to also look at homocysteine and methylmalonic acid levels because they go up when B12 is low. So you get a baseline, and then after a month on metformin, you see what happens to B12, homocysteine, methylmalonic acid, and you see whether things are changing. And if they are, then you tell the patient, take a Tums with each metformin tablet, and then you see what happens by measuring blood levels. As a matter of routine, once I've got a person rolling on metformin without any adverse B12 absorption effects, I'll recheck maybe these 3 tests in 6 months or a year, and I'll do it again in another year or so, just to make sure B12 absorption is not being impaired. And one other warning is that we found that the generic metformin is much less effective on blood sugar than the brand name glucophage. And I've repeated that over and over in my various communications. So finally, we could get down to questions. First question: does excess injected insulin raise cholesterol? Well, first of all, why are you worrying about cholesterol? If you're diabetic, you should be worrying about blood sugar. The cholesterol myth has pretty much been abandoned by the bulk of the medical profession. It has, if anything, there has been higher mortality in some groups with very low cholesterol levels, but total cholesterol is no longer a risk factor for heart disease. We do look at a related measure called oxidized LDL, which or glycated LDL, both of which can be affected by high blood sugars. So I would say don't worry about cholesterol. And injected insulin is a replacement for missing insulin. And one could say, well, all humans have a high cholesterol because they're making insulin. Well, insulin doesn't do that anyway, so it's something you don't worry about. I just think that it's a subject that has no meaning. Large amounts of injected insulin injected to cover excessive intake of carbohydrate, as advocated by the American Diabetes Association, will cause obesity. And the obesity will cause all kinds of problems, including cardiac disease. So the game plan is not to eat a lot of carbohydrates, so you don't have to inject excessive amounts of insulin. Next question: would you use liquid Band-Aid on heel and fingertip cracks or peeling heels? In the past, it has been very effective for me to close the cracks fast. Well, if it's been effective, I say use it. If you have fingertip cracks, it right away reminds me of psoriasis, which affects virtually 100% of diabetics and has not been adequately recognized in this regard by the medical profession. And many people with psoriasis get cracked fingertips in wintertime. Why, I do not know. And what you can do is lubricate your fingers before you go out in the cold. Maybe you might want to use coconut oil, which is well absorbed. I remember in the past using a mild steroid ointment, 0.5% hydrocortisone, which seemed to prevent and close up these cracks. Uh, Another thing that theoretically can be used would be gentian violet, which is an antiseptic uh, that leaves a film that protects the open crack from infection. As far as cracks on the heels go, that usually stems from sympathetic neuropathy, which many diabetics have, where they're unable to sweat in their feet. In many cases, I've seen this reverse with absolutely normal blood sugars. But in the meanwhile, you should be lubricating your feet twice a day to prevent the cracks. And again, the easiest stuff to find is olive oil, and it's very effective. But palm oil is probably better absorbed. I have pressure points on bottom of feet which are painful when walking. Doctor recommended new shoes before he would recommend orthotics. Besides moisturizing with oil, what else would you recommend to stop the pain until the shoes and orthotics start to work to heal the pressure point? Well, first of all, if the pressure point is a wound, like a callus with an ulcer under it, that has to be attended to by a wound care clinic or a wound care specialist. If the pain is just from the pressure from the shoes, the game plan should be to immediately relieve it, not to experiment and wait. What I would do when I was doing this kind of thing in clinic, and I still do it in my office, is I will take out of my inventory what's called a cast boot, which is a removable shoe that comes in a variety of sizes. I take one, the patient's size, and I would I would glue to the sole of the cast boot some cushioning material. It might be leather, it might be plastic, to take the pressure off the site that's hurting. That's the short-term game plan. So you could go to a podiatrist who could do that immediately in his office. And if he can't do that, he's not the podiatrist you want to see. Then you go to a shoe store with a replica of the little pad that is sitting in the cast boot. And you try on a variety of shoes, but have the pad stuck in the shoe temporarily. You could use double stick tape to make sure that the shoe fits with the insert in place. Then you take the new shoes back to the podiatrist and have him glue in an insert that matches the one in the cast boot. Now, sometimes just a standard arch support will do this. Sometimes you have to glue this post, as it's called, the extra piece of material. It's called posting. You have to glue that underneath the arch support. There are lots of ways that this can be done, but it should be done by a professional person, and the pain should be stopped immediately if it's caused by the pressure. If it's caused by pressure plus a hidden ulcer, that has to be determined. But I will not walk around in shoes that are too tight. I will do something immediately. It happened to me a couple of weeks ago. My sneakers started hurting me at the gym. Never happened before. So right away at the gym, I found that they had built-in arch supports that came with the sneakers. And I found that if I took them out, the sneakers didn't hurt. So right on the spot, I took them right out. I'm a type 1 with hypothyroidism, which is causing lymphedema in legs. Would you advise going to a lymphedema program to treat in addition to thyroid medication? It's interesting that I've only seen 2 cases of this in 30 years of medical practice. I see hypothyroidism in about 90 or 95% of my patients, but lymphedema in the legs very rarely. And I learned from a patient that a product called Serratio, which is a pill, it's spelled Serratio, helps reduce the lymphedema. The other aspect of it is both of these people were being treated for hypothyroidism, but they were not being treated to normalize their free T3. And the game plan is to get the free T3 in the middle of the normal range, which means, in all likelihood, that you should be treated with both levothyroxine, which is T4, and timed-release liothyronine, which is T3, which you get from a compounding chemist. And the lymphedema can last for years after you have normal T3 levels, and that's why it may be of value to take the Serratio in addition. I don't know of any other solutions. This is a very difficult problem. Can PCOS continue to affect my diabetes post-menopause? Can you recommend reading materials or other sources of information? PCOS is polycystic ovarian syndrome, and it is very mysterious in that we probably do not know why this causes insulin resistance and is strongly associated with the onset of diabetes in young people. There are only one or two investigators in the country that are seriously looking at this syndrome. And yes, it can affect insulin resistance post-menopause. So these people frequently have trouble losing weight. You put them on a very strict diet, very low carbohydrate, low total calories, and it's as if they're living on air. They still don't lose weight. It's pretty mysterious. Metformin helps, and Avandia helps. So I use both of these products to treat my patients who have PCOS. I use them at the same time. And as far as sources, you could scan the internet as well as I can. There have been many articles written about it, but they cover varying aspects of it, and I don't think anything on the internet has an adequate solution to the problem. But metformin, or I should say glucophage, and Avandia are helpful, very helpful. Next question. 47 years old, A1C is good. I don't know what that means. Diagnosed on a 4-hour test that I am insulin resistant. I guess someone gave the patient glucose by mouth and measured blood sugars every half hour for 4 hours and also measured serum insulin levels. Sugars up and down. Diagnosed with gastroparesis. Is this the reason for all my stomach issues, along with my unstable sugars, and why I can't lose a single pound? How can I control my sugars with the types of food that is suggested for gastroparesis? Well, this question is just asking to read my book, because we have a whole chapter on gastroparesis. There are medications for it, and if this person has severe gastroparesis, he probably has to be on liquid meals. So my people with severe gastroparesis cannot remotely control their blood sugars unless they're on very low carbohydrate diets, liquid meals, and getting the medications that we use to treat gastroparesis, which are a combination of both domperidone and Zofran. And these are covered in my Dr. Bernstein's University videos and also on recordings of these teleseminars. Father of 3-year-old type 1, and follow your low-carb diet. We have been experiencing difficulties with meals that contain cheeses or any dairy. Any meal with dairy will cause a massive blood sugar spike several hours later. Could you please provide some insight into this phenomenon and suggestions? Well, first of all, I'd suggest that you read my book and follow the guidelines very carefully. Also, that you weigh the protein portions of his meals. Dairy foods are not free. They contain both protein and carbohydrate. And it could be that this parent is assuming that they're freebie foods. I have not heard of massive blood sugar increases when people take dairy products that are covered by the right amount of insulin. On the other hand, if they're taking dairy products that have a lot of carbohydrate, their blood sugars are going to soar. So milk, especially skim milk, will send the blood sugar way up. Many of the yogurts, especially the sweetened yogurts, will send the blood sugar up. Dairy is not a freebie, so you have to look at the guidelines in the book for treating, for using insulin to cover both protein and carbohydrate. Now, you could do an experiment. If you really think that the dairy, not the protein and carbohydrate, are causing the increase, you cut out all dairy, work out a meal plan, and then get the blood sugars normalized. And at that point, you substitute a dairy product, let's say 3 ounces of cheese, for 3 ounces of protein, plus 3 grams of carbohydrate in a particular meal, and see if the blood sugars from that meal go up higher than they did for that meal on the prior day when you didn't have the dairy product. That's about all I could recommend. I've never seen a strange increase in blood sugars caused by dairy. One situation, people who are lactose intolerant and take Lactaid with the cream for their coffee will find their blood sugars going way up because the Lactaid converts lactose to glucose. Or if they're having Lactaid when they eat cheese, that will convert lactose to glucose and make that lactose sugar much more rapid acting. Okay, next question. If blood sugars are rising, then what levels of ketones are of concern? If normal range of ketones on diet are 1 to 3 millimoles, then the urine will always have ketones present. But if the blood glucose is high, are these levels dangerous or are they needed to be above 4 millimoles? I don't know why this person is measuring his urine for ketones. Or is he measuring his blood? Some people are doing that too. There's no reason to do this. And if your blood sugars are so wild up and down, and you're on a high carbohydrate diet and you're going into ketoacidosis, that is another story, but you should be controlling your blood sugars. Diabetics should be looking at blood sugars. Ketones are only of significance when they get very high. And if you're on a low carbohydrate diet, and if you're following the guidelines of my book, Diabetes Solution, you're not experiencing extraordinary blood sugars, and certainly not for prolonged periods of time. Should not be a problem. In the book, we speak of sick day, where people have vomiting and diarrhea, and if they're not on top of it real fast, might go into ketoacidosis, get severely dehydrated. There, checking for ketones is of value. But again, even there, it's blood sugar control that's important. So this is spinning wheels. It's not addressing the underlying problem, which is blood sugars. I cannot remember when I tested my urine for ketones. Yeah, in the old days, before we had blood sugar self-monitoring, we had a little system for testing urine for ketones. And it didn't tell me anything because every other day I'd have 4+ urines all day, and I'd test for ketones and they'd be high. And it didn't tell me to do anything because I didn't know what my blood sugars were. I love to eat cold potato salad or white bean salad. Is resistant starch okay for diabetics? Well, what you're eating is starch that rapidly turns into glucose. And if you follow the experiment that I demonstrated on video about 15 years ago, just chew some of the potatoes or the beans, spit it on a Clinistix, which is a urine test strip for glucose. You'll see that the potatoes and beans instantly turn into glucose. I'd suggest that you read my book, Diabetes Solution. I have been developing lumpy feet over the last year. My morning blood sugar reading is about 102. Any recommendations? Yeah. Check your blood sugar 1 and 2 hours after meals. If your lumpy feet feeling is secondary to neuropathy, that's usually caused by high blood sugars. And checking fasting blood sugars, like many physicians recommend, is not going to catch the highs that cause the neuropathies. You want to get the highest blood sugar of the day, not the lowest blood sugar of the day. And I'd suggest that you read my book and that you do what it takes to keep your blood sugars normal around the clock. Now, there might be other reasons for your lumpy feet. Maybe there are lumps in your shoes. But certainly, just looking at fasting blood sugars tells you almost nothing. "61-year-old Asian physician with type 2 for the last 3.5 years. Using your methods, my A1C is down to 4.6 on metformin and acarbose. What do you think of acarbose?" Well, I spoke of acarbose earlier in this teleseminar, so I'm just going to tell you that you should be cutting down the carbohydrate, and if you do that, the acarbose will be of no value. And I want to remind you to stay away from open flames. I don't know what the word for explosion is in your language. Is it sufficient to maintain an average blood sugar of 85, or must one have a constant blood sugar? Sometimes I run up to 140 and sometimes drop to 60. Well, ideally, you should have a level blood sugar. For most diabetics, even type 1s, it's possible to do this. If you look at the website Type 1 ONE GRIT, G-R-I-T, you'll see the continuous glucose tracings of people who have read my book, and you can see that it is possible. But some people have problems. Maybe they cannot eat consistently. Maybe they do a lot of traveling. I would have to sit here and think what problems people run into that make it hard for them to have absolutely level blood sugars. Probably it has to do with eating the wrong things or making mistakes. So read the book Diabetes Solution. Since the publication date of the most recent edition of Diabetes Solution, several new forms of insulins have come to market. In particular, I'm wondering whether a truly long-lasting version has come to market. And then he says, he talks about the Lente insulin that I've spoken about, but I haven't spoken about Lente. I've spoken about Ultra Lente, which was taken off the market inappropriately. We do have a new insulin. I've mentioned it repeatedly on my teleseminar and also in my videos, and it's called Tresiba. Tresiba must still be taken twice a day. I might point out that most doctors are not prescribing long-acting insulins twice a day for type 1s, but they should be, because they don't last 24 hours unless they're given in super doses that are not what are called basal doses, unless they're given in doses that cover meals also, and this just doesn't work. So you have to take Tresiba twice a day, but it lasts overnight much better than Levemir or Lantus. And I recommend it very highly, and virtually all of my type 1s are now using Tresiba. Your thoughts regarding the Omnipod with the Dexcom CGMS. This is an attempt at achieving closed-loop blood sugar control. I recommend Dexcom continuous blood sugar monitors for all insulin users who live alone, so that the alarm on the monitor will warn them of possible hypoglycemia. So I have a lot of patients using these things. But to hook it up with an insulin pump that causes all kinds of new problems and doesn't really bring anything positive into the act makes no sense. The formulas that you're given for the insulin pumps are worthless. There's a pretense that you could eat whatever you want, guess at the amount of carbohydrate, ignore the amount of protein and fat and bulk, and set a dose, and your blood sugar will be normal. And what you see is blood sugars like this. And if you go to Type 1 GRIT website, Type 1 GRIT website, you'll see the before displays that occur when people are using insulin pumps uh, and not having consistent meals, having high carbohydrate, et cetera, et cetera. They just don't work. On top of that, they cause the formation of scar tissue that eventually makes the absorption of insulin into the pump sites very unpredictable and difficult. So the end result over a period of years is quite harmful, not helpful. But getting continuous glucose monitor, which is an estimate of your blood sugar, is helpful for preventing emergencies. Does not take the place of using a good blood sugar meter like the one that we've been recommending, or the two that we've been recommending. Is it possible for type 1 patients to have negative antibodies, such as, and he lists a few of them? If yes, then what are some other diagnosis tests you would suggest to determine type 1 diabetes? Well, as you know, when a person is being attacked with antibodies that cause type 1 diabetes, you can measure them, but you don't know when you're going to find them. And there are now probably dozens of different antibodies that can be involved in the etiology of type 1 diabetes. So even testing for them is of questionable value. To me, the important thing is to control blood sugars. And it doesn't matter what name you put on the diabetes. The only way I know of to absolutely, aside from killing a person by taking his insulin away, is to absolutely know this is a type 1 diabetic, is to measure his C-peptide level. That's a measure of the amount of insulin he's producing. And if the C-peptide level is 0, then you know that he's a type 1 diabetic. But many type 1s make small amounts of insulin, so they may have small amounts of C-peptide. So even that test is not an absolutely accurate test. But why, again, why be bothered putting a number on it, a name on it, when the game plan is to normalize your blood sugars? And there are plenty of people who start off with type 2 diabetes, they're obese, and they follow the ADA diet and play the ADA game for years and years, and eventually they burn out virtually all of their beta cells and exhibit the same insulin pattern as type 1 diabetics. What do you call them? Does it matter? The treatment would be the same. Okay, let's see what's next. My physician has prescribed Janumet XR for years. Now Cigna, that's the insurer, denies the prescription because it is not on their formulary. What would you recommend as a substitute? I would consider paying the increased price for the best drug. Well, I would certainly use Glucophage XR, which is the original metformin. The Janumet is a mixture of Januvia and metformin, and as I've said before, Januvia has almost no effect on blood sugar, so it probably would not make a difference. And if you're using the original metformin formulation, Glucophage, there's a good possibility that it may even be more effective than the Janumet. So give it a try and good luck. We're now at the end of our session. Our next teleseminar will be Wednesday, August 31st at the same time. Thanks for tuning in. We look forward to seeing you then. Bye-bye.